Achalasia. So in this video we are going to discuss this disorder. Mainly the symptoms are dysphagia, and usually it occurs for both fluids and solids at the same time. Achalasia means the inability to relax, and the etiology starts from the structure in the esophagus, distal esophagus. It's called the lower esophageal sphincter. Now this lower esophageal sphincter is inhibited by neurons, are called the inhibitory neurons. By this inhibition, the lower esophageal sphincter relaxes and allows food to pass into the stomach. What happens in achalasia is the inhibitory neurons function is cancelled or disturbed for any reason. This will cause high resting pressure of the lower esophageal sphincter, banning both fluids and solids from entering the stomach. Now, for diagnosis, the esophageal mucosa would appear normal on EGD. So if we do a scope, we would find a normal mucosa. However, when we have to do EGD, there are certain cases that it is a must to do it. So if we have any alarming symptoms or features like anemia, age more than 50, or have weight loss, vomiting, and also we have risk factors like smoking, alcoholism in the history of the patient, and also we have FOBT positive in the stool, melena, and as we said, also weight loss. Now, we do EGD in these cases to rule out pseudoachalasia. Pseudoachalasia, it's a tumor usually at the site of the lower esophageal sphincter mimicking achalasia. So if we have a background in the case mentioning any of the previous features, we have to do EGD to rule out malignancy and not just take it as achalasia for diagnosis. So otherwise the mucosa would appear normal on EGD. Now, when we to do manometry is to insert a tube. It has a measuring points to measure pressure within the esophagus. In achalasia, it would show us in the body of the esophagus a peristalsis, and at the lower esophageal sphincter, we would see a high resting pressure as the definition of achalasia. Now, for the treatment of achalasia, we can do multiple options. So if we have a scope with balloon, we do something called balloon dilatation at the level of the esophageal sphincter. We insert a balloon and then inflate it to cause dilatation of the lower esophageal sphincter. We have also surgery to do myotomy to cut the muscle, and Botox injection also to inject Botox in the lower esophageal sphincter, causing it to relax. Now, for the Botox, it needs to be repeated every 3 to 6 months. For the surgery, we need a good surgical candidate patient. So not all the patients are candidates for surgery. Especially, we should look into the patient's history. For balloon dilatation, we have the risk of perforating the esophagus. So for clinical scenarios, think of if they mentioned that the patient has underwent balloon dilatation and then he has fever, think of perforation of the esophagus. Otherwise, if he is a poor surgical candidate, then go for Botox injection. Now, also barium swallow is done in the diagnosis as initial step. It's not the most accurate test. The most accurate is manometry. We do EGD to rule out pseudoachalasia. But in barium swallow is done in achalasia. It shows the bird's beak, as in this image. It is called the bird's beak. We do it as initial step. If the question asks for the initial step, then we go with the EGD. We go with the barium swallow. For EGD, if we have a high-risk patient, initial step we do barium swallow, and the most accurate test is to do the manometry. Now, for diffuse esophageal spasm. In this disorder, we have intermittent symptoms. Spasm of the esophagus. It happens all over the esophagus. So the symptoms are intermittent. So we have intermittent chest pain evoked by hot fluids or cold beverages, and outside the episodes, the patient is normal. So it is just like a variant angina or it's like asthma. We have a spasm of the esophagus. Now, this spasm, when it happens in chaotic way. Usually, the normal movement of the esophagus, it happens in harmonic way, allowing the food to go into the stomach. In DS, it happens chaotically and all over. This is why it causes the chest pain. To note, if you feel the patient has a history of cardiac risk or factors, then do EKG to rule out any acute coronary syndrome. Otherwise, we initially start with barium swallow to see the corkscrew esophagus or nutcracker esophagus, but the most accurate test is to do manometry and to check the pressure within the esophagus. For the treatment, what we are going to give is CCB, calcium channel blockers. If this didn't work, then we go to give nitrates. However, some patients respond to tricyclic antidepressant, the TCAs, and it is very important not to miss EKG on patients in patients who has high risk factors for acute coronary syndrome, and to do EGD in case of any alarming features like weight loss, iron deficiency anemia, vomiting, age more than 50, melena, and the guaiac positive test.